Hello students, my name is Dr. Ominde and I'm going to continue with my lecture series on the pelvic viscera. We were discussing the clinical and applied anatomy of the pelvic viscera. So I'm going to continue with that. So we'll begin with what we call ectopic pregnancy. You know that normally the implantation of the developing embryo occurs on the upper posterior wall of the uterus at the endometrium. So any implantation that does not occur at the upper posterior wall of the uterus is called ectopic pregnancy. So when it occurs at the isthmus, when it occurs at the cervix, when it occurs at the fallopian tube, the ovaries, in the intramural part, some can go to the abdomen at the peritoneum, some implantation can occur within the abdominal viscera like the liver. All this we refer to as ectopic pregnancy. But majority of ectopic pregnancies occur at the fallopian tube. Remember, fertilization occurs at the ampulla. Then another clinical correlate is the urethral rupture and urine extravasation. So the spongy urethra is usually unprotected superiorly and its wall is thin and distensible. So when especially this occurs in male, so when they fall astride and fall, let's say one limb falls inside a manhole, we call them straddle or manhole injuries. The urethra is usually torn, and this extends, extravasation of urine usually extends to the scrotum, the penis, and anterior abdominal wall because of the extension into the superficial perineal pouch. Then we also have urethral constriction, and the urethra has constrictions at the external urethral orifice, and the membranous urethra also is the narrowest portion. So the external urethral orifice is the narrowest part, while the membranous urethra, out of the three parts of the urethra, the membranous urethra is narrower as compared to prostatic urethra and the penile or spongy urethra. That diagram shows you where uterine rupture can occur. Okay, so at the shaft of the penis, at that region. So when a rupture occurs, because of continuation of fascia from anterior abdominal wall to that of the penis and scrotum, this yellow shows you how urine will extravasate. So due to that continuation of Bach's fascia with Scarpa's fascia of anterior abdominal wall and the fascia of the scrotum, so urine will tend to go upwards to the anterior abdominal wall and downwards into the scrotum. The urethra has curves, so you need to remember that because these curves of the urethra will be important during catheterization of the urethra. So the membranous part usually runs inferiorly and anteriorly as it passes through the urogenital diaphragm, while the prostatic part is concave anteriorly as it traverses the prostate. Then we have urethral strictures. Strictures are just narrowing within the urethra, and this is due to scarring. Okay, so healing by forming scar tissue, and this is following external trauma or infection. So these are usually dilated by passing instruments, and that's called urethral sounding. So you pass a urethral sound so that you can dilate the narrow portion of the urethra. So if you look at this diagram, you can appreciate that at this portion there is narrowing of the urethra. That's what we call a urethral stricture compared with a normal urethra here. Then we have autonomic bladder. This is whereby in spinal cord injury or spinal cord disease, the innervation to the external bladder sphincter is usually affected. Therefore, it will contract reflexly on feeling and expel the urine. So the bladder is autonomous of voluntary control. Remember, the external bladder sphincter is innervated, has voluntary control, while the internal one has autonomic control. So in spinal cord injury, you lose the voluntary control. So the moment the bladder feels, it just expels urine uncontrollably. Then we have cystostomy. This is whereby you create an opening of the urinary bladder onto the anterior abdominal wall, especially in patients who have urinary retention due to urethral stricture. So the urethra is severely narrowed. It cannot release urine from the urinary bladder. So the patient has a lot of pain due to urinary retention. So cystostomy is where you create an opening of the bladder onto the anterior abdominal wall. You may as well introduce a catheter through the anterior abdominal wall. We call it suprapubic catheterization in order to drain the urine. The urinary bladder may rupture. So during when the bladder has filled completely and it's distended, its position is high from the pelvis to some part of the abdomen, lower abdomen. So it's easily ruptured when it's distended, and this is by injuries to the inferior part of anterior abdominal wall or fractures of the pelvic bones. And this may lead to extravasation of urine into the peritoneum or outside the peritoneum. With prostate, we had already discussed benign prostatic hyperplasia, where we say the prostate enlarges, okay, and because it surrounds the prostatic urethra, it obstructs urine drainage from the bladder, leading to urinary retention in old men. And the treatment for this could be prostatectomy, where you surgically remove the prostate, or you can do what you call TURP, transurethral resection of the prostate, where you resect the prostate by passing your instruments through the urethra. Then we also have cancer of the prostate, among the most common tumors in male. This usually spreads via blood or lymphatics, and the spread metastasis can get to the vertebral column and to the spinal cord and pelvis because of communication between prostatic venous plexus and the vertebral venous plexus. And these communications are valveless, to mean that blood can move in whatever direction. Then digital rectal exam is what is mainly used to feel the prostate gland. So you're able to decide, has it enlarged? Does it have a rough surface? How is the mucosa on top of the prostate, and so on and so forth. So digital rectal exam, when you pass your finger into the rectum and palpate the prostate, it's very important in the diagnosis of prostate pathologies. So this is a normal prostate, and this shows an enlarged prostate, and you can see, look at the patency of the urethra. Its prostatic urethra is narrowed here. This is normal, so it's going to cause urine retention within the bladder. Then we're going to discuss internal iliac artery. The internal iliac artery is the main blood supply to the pelvis. It comes from the common iliac at L5S1, where common iliac divides into internal and external iliac arteries. The surface markings, you get the internal iliac at the upper point of trisection between anterior superior iliac spine and the pubic symphysis, and it's usually about 4 centimeters long. This artery is crossed in front by the ureter, and it's separated from the sacroiliac joint behind the internal iliac vein and the lumbosacral trunk. In upper part, external iliac vein and psoas major are lateral to it, and in the lower part, the obturator nerve is lateral to it. So this is the common iliac dividing into external iliac. Remember, deep to the inguinal ligament, external iliac continues as femoral artery. Then this is the internal iliac with its branches, okay? So you have iliolumbar, lateral sacral, the superior and inferior gluteal, internal pudendal, middle rectal, uterine, superior vesical, and umbilical artery. So the branches of the internal iliac are divided into parietal branches and visceral branches. So we have iliolumbar, which has iliac branch and lumbar branch. Iliac branch to the ilium and iliacus muscle. Lumbar branch supplies quadratus lumborum and psoas major. Lateral sacral artery will supply the spinal cord, and the obturator artery has muscular branches to obturator internus and externus, a nutrient branch to the ilium and the pubis, and acetabular branch through the ligamentum teres that is at the head of the femur. Then superior gluteal artery is another parietal branch to gluteal muscles, specifically gluteus minimus and medius, while inferior gluteal artery supplies the gluteus maximus muscle. Internal pudendal artery has different branches, an inferior rectal to the rectum, posterior scrotal and labial branches to scrotum and labia majora, perineal artery to the perineum, artery of bulb of penis to the penis, a urethral artery to the urethra, and deep and dorsal arteries to the penis or clitoris. Then the visceral branches include umbilical artery that gives superior vesicle to the upper part of bladder and medial umbilical ligament, while artery to vas deferens supplies lower part of the ureter, the seminal vesicles, the back of the bladder, and urethral branches of the ureter. Inferior vesicle artery is also a visceral branch of the internal iliac and supplies the lower part of the bladder as well as the prostate, seminal vesicles, ductus deferens, and lower part of the ureter. Uterine artery supplies the ureter, the upper part of the vagina, the middle part of the fallopian tubes, the round ligament of the uterus, and the ligament of the ovaries, while vaginal arteries will supply the front and back of the vagina and give some branches to the bladder, rectum, and bulb of the vestibule. The middle rectal artery supplies the rectum, prostate, seminal vesicles, and ductus deferens. So we have collateral circulation whereby after obstruction of the internal iliac, anastomosis between vessels will give collateral or alternative blood supply. So anastomosis between branches of the opposite internal iliac, parietal branches and branches of femoral artery in the thigh, as well as superior and middle rectal arteries, will come and supply in cases of internal iliac obstruction. So the collateral channels supply the lower abdomen if abdominal aorta is obstructed, and lower limb if femoral artery is obstructed. We have three other arteries that enter the pelvis: the median sacral, inferior mesenteric, and ovarian artery. Internal iliac vein is a short trunk that unites with external iliac to form common iliac vein. Its tributaries will correspond with the branches of internal iliac artery, except umbilical and iliolumbar arteries. The pelvic viscera have venous plexuses which communicate freely, and these give visceral tributaries of the internal iliac vein. The plexuses communicate with the parietal tributaries, and this explains the spread of infection. So we have different plexuses: the rectal, venous plexus, vesical, prostatic, uterine, vaginal, and sacral venous plexuses. Next, we are going to discuss the innervation of the pelvic viscera.